This is my project change proposal for reducing heart failure readmissions. Cardiovascular disease is the leading cause of death, with death due to heart failure increasing, especially in people living in rural communities. People living in rural areas are often faced with more social risk factors related to poor health. These disparities can create more challenges for these people living with heart failure, including increased readmission and mortality. Implementing a program to increase patient education and medication reconciliation prior to discharge and post-discharge follow-up phone calls to monitor symptoms and ensure follow-up appointments are kept has the potential to decrease cost in this rural community hospital due to unnecessary heart failure admissions and readmissions and improve the quality of life of people living with heart failure in this rural community. People in rural communities often experience lower educational attainment, lower income, and poor access to health services, including primary care and specialists, creating more challenges for people living with heart failure in these communities. These factors result in higher incidence of both preventable hospitalization, 30-day readmissions, and mortality related to heart failure in this population. In fact, Pierce et al. Reported a higher age-adjusted mortality rate due to heart failure in rural adults compared to those living in an urban setting every year from 2011 to 2018. When discussing heart failure in hospital admissions and readmissions, micro-level issues relate directly to the patient themselves and the staff caring for them on the hospital unit during admission. I feel that this is the level most directly impacted by heart failure in rural communities, because often these issues are overlooked and contribute directly to the admission and readmission rates at a rural community hospital. As discussed, the patients in rural communities often have lower socioeconomic status and educational attainment, which often leads to poor health literacy. If nurses on the unit do not educate patients at a level that they can understand regarding symptom management and when to see their doctor, then it's the same as not educating them at all. If the nurses on the unit are not properly trained and educated on heart failure, then they could potentially omit important information when doing patient education prior to discharge. If the hospital unit caring for heart failure patients is overwhelmed with unnecessary admissions and readmissions, then it contributes to a shortage of staffing, which prevents nurses from being able to spend adequate time with each patient doing medication reconciliation, discharge teaching, and post-discharge follow-up. This leads to inadequate education, specifically regarding symptom management and when to call their provider in an effort to avoid future preventable hospitalizations. Interdisciplinary communication and teamwork are crucial for heart failure patients. Having an open line between physicians, case managers, and nurses helps ensure continuity of care and that all team members are on the same page and working toward the same goals. At this hospital, there are interdisciplinary team meetings on each unit at a designated time where all these team members meet to collaborate and discuss each of their patients, the next steps, and their plan of care moving forward. This is a daily opportunity for nurses to relay information about gaps in knowledge they have observed and work with other team members on the best way to address these issues. Since this is a not-for-profit hospital, all money coming in is redirected back into the hospital, which allows for adequate resources that could be directed towards programs to address heart failure, including pre-discharge education and post-discharge follow-up. One of the biggest strengths is that there's already an education program in place for diabetic patients that are admitted because of medication noncompliance or exacerbation of symptoms, which can provide somewhat of a framework and starting point for a similar program to address heart failure and help the hospital decrease their 30-day readmission rate. High staff turnover will be a barrier to implementing pre- and post-discharge programs because they require extra training to make these programs successful. Training people correctly will be more difficult with continually changing staff. Having staff dedicated to heart failure education could help address this issue, as these staff members would be primarily responsible for patient education and could help identify patterns in patients' knowledge gap and incorporate that into standard teaching of all heart failure patients. Being in a rural area as part of a bigger hospital system means that most specialty physicians serving the hospital do not live close by or may not have practices in the area. Some only practice in the area 1 or 2 days a week, which means that once discharged, the patients may not be able to follow up with the same specialist that they saw in the hospital, which can disrupt the continuity of care. COVID has also presented a few barriers. Before COVID, one resource to help educate heart failure patients regarding symptoms and when to contact their provider could have been group education classes that would also provide support and connect patients with others with similar diagnoses and create community. While there may be opportunity for virtual classes, I think patients, especially older patients, are less likely to participate in those programs. With COVID, patients are more likely to avoid doctor's offices for fear of exposure, especially if they consider their symptoms to be mild and allow those symptoms to progress to the point of needing hospitalization. With COVID, we've also seen an increase in travel nurses, especially at this rural hospital where a lot of staff nurses already commute. This has an impact on units serving heart failure patients because nurses may not be as familiar with the extra educational programs implemented for these patients and may discharge them as they would any other patient without providing the additional resources, education, and follow-up instructions necessary. So I chose Lippitt's theory of change for 3 reasons. The first reason is because it follows Lewin's theory of change, but in greater detail to guide each step. This provides a structured framework to help build change on. Before moving to the next step in Lewin's theory, there are several steps to focus on to ensure each of the 3 stages of Lewin's theory has been achieved before moving on to the next. The second reason I chose Lippitt's theory is that it allows a focus on the responsibility of change agents throughout the process. The staff providing education and the patients are crucial to implementing this change. The staff must understand the importance of the education if they are expected to want to implement this change that is adding to their workload, and the patients must realize that their understanding and implementation of this new knowledge is imperative if they want to change their outcomes. Finally, I think that to implement a change in discharge teaching and help patients with behavioral changes, it is very important that all parties involved can see the proposed outcome and that it seems attainable. This change has a very specific goal of decreasing the rate of readmission, and that is not only attainable, but also benefits both patients and staff. The top 3 quality outcomes to be achieved by implementation of this project would be to decrease the overall number of heart failure admissions and also the 30-day readmissions, both due to exacerbation of symptoms that could be addressed by changes to plan of care or medication regimen if addressed by a provider in their office when symptoms are more mild. Ultimately, this leads to a decrease in the cost to our hospital directly related to heart failure, hospitalizations, and also fees associated with high rates of 30-day readmissions. For this project, we'll follow a Plan, Do, Study, Act, or PDSA improvement model. The use of this model will allow us to plan changes, implement these changes, determine if the changes are beneficial and effective, and act accordingly. Because this model is cyclical model, it allows us to continually evaluate and make changes based on our observations. So since we implement the program and find what is working and what isn't, this model allows us to continually evaluate what changes to keep and what changes need to be modified based on direct observation of improvements and where we need to continue to improve. The financial implications for this project include an addition of educational staffing to ensure proper pre-discharge education of patients, handouts for patients regarding symptoms and medication management, additional pharmacy resources for proper medication reconciliation, and development of an application to help keep track of patient follow-up calls and monitor rate of follow-up appointments kept and attended. There will also be expenditures for staff involved in the planning process, training staff, and monitoring during the first year of implementation. Personnel costs for project planning meetings include paying an APRN, a unit nurse manager, 2 registered nurses, 1 unit secretary, 1 pharmacist, and 1 IT specialist for 6 one-hour planning meetings. In addition, the RNs and unit manager will have 4 additional meetings to help find and recruit champions of change and determine the most appropriate time and how to implement pre-discharge teaching and follow-up phone calls. The initial training cost requires approximately 2 hours of time from the nurse manager, 6 RNs, and a unit secretary from both day and night shift. Once the project has been implemented, it will require 12 hours per year for the APRN to attend monthly meetings to monitor, about 52 hours per year for weekly meetings to monitor success and failures of the program. 4 RNs will spend an average of 3 hours per week doing patient education, follow-up phone calls, and meetings for a total of 1,092 hours per year. The unit secretary will spend approximately 1 hour each day documenting completion of discharge instructions and follow-up phone calls. And the IT specialist will spend approximately 12 hours to initially develop a program to monitor education documentation in charts, follow-up phone calls, and follow-up appointment, and then attend monthly meetings for a total of 24 hours for the first year. Supplies, including patient handouts and application development, will cost around $1,500 for a total first year cost of $149,188. The approximate cost per 30-day readmission is $2,000, with the current occurrences being around $735 per year for an annual cost of $1,470,000. If this project can achieve its goal of reducing 30-day readmissions by 20%, then that would decrease the readmissions by 147 per year for a cost avoidance of $294,000 per year. Since our return on investment is calculated by our savings minus our investment divided by our investment, our projected return on investment would be 97%. In order to gain the support of frontline staff, we will engage key staff members and identify change agents to help reinforce the importance of discharge teaching. We will assess the level of education needed to get everyone on the same page and distribute information regarding reduction in readmission rates with early symptom identification and current readmission rates. To engage executives and providers, we will present current data and subsequent costs related to heart failure readmission to reinforce the need for such a project and the cost benefit. We will build an implementation team consisting of champions of change to engage other staff. We will involve leadership and we will recruit different members of staff to integrate a variety of skills and ideas. Finally, to promote adoption and sustainment, we will print and distribute educational materials to ensure patients are all being delivered the same complete information, monitor and evaluate the success of the program monthly, provide debriefing sessions for an opportunity to discuss successes and failures, and give staff an opportunity to present ideas, and we will use reward and recognition to provide inspiration to team members and show appreciation for them committing the time and effort to implement this change project. The primary stakeholders that need to be communicated with on this project are the patient and family members, the providers, the nursing staff, and the administrators. If the program is ineffective and not achieving desired outcomes, the providers, nursing staff, and administrators need to know which aspects of the education program are effective and which aspects need to be improved upon to determine what can be changed to provide better outcomes. If the program is effective in producing favorable outcomes, the patient and family members need to know the importance of the discharge instructions and that understanding of these instructions decreases their chances of readmission and improves their outcomes. This needs to be discussed with them prior to discharge with written and verbal feedback, but would not require regular updates of the patient and family members. Nursing staff needs to know that the program participation is creating better outcomes for their patients and is an effective way to help their patients prevent avoidable readmissions. They should be updated during morning huddle daily, which should be summarized and also sent through weekly emails to ensure it reaches part-time nurses and those on vacation. Monthly metrics will also be reported during monthly staff meetings. Providers need to know if this program is effective in reducing the 30-day readmission rates and should be updated at least monthly. These updates should be delivered through a summary of the monthly nurse meetings via email. Administrators need to know that this program is having a positive effect on patients' health and a positive impact on hospital data, patient satisfaction, and hospital finances. This should be presented at least quarterly via email in the form of a summary of the metrics presented in the monthly staff meetings. To evaluate the effectiveness of this project, we'll focus on outcome, processes, and impact measures. The outcome measure of decreased 30-day readmission due to heart failure will be assessed 6 months after the start of the program, with a goal of 20% reduction. Process measures regarding discharge instruction, documentation, and patient and family member satisfaction with discharge instructions will be assessed 6 months after implementation, with a goal of increasing from 30% to 75%. We will aim to have all staff trained within 60 days of the start of the program and within 30 days of hire for new employees. The impact measure will be a goal of avoiding fees associated with high heart failure readmission rates after the program has been in place for at least 12 months. Finally, since we know some programs have unintended consequences, we will have a balanced measure of maintaining at least the same rate of follow-up appointments attended post-discharge to ensure patients aren't canceling appointments because they feel the extra education and follow-up are adequate, and understand the importance of keeping follow-up appointments to monitor medication regimen and symptom management. The implementation of a program to standardize pre-discharge teaching and medication reconciliation for heart failure patients, along with follow-up phone calls post-discharge regarding symptom management and follow-up appointments, will provide benefits to this rural community hospital and heart failure patients in this rural community. The program will decrease 30-day readmissions and unnecessary admissions due to symptom exacerbation by following up with patients post-discharge to make sure they have a thorough understanding of medication regimen and when to call their provider, and ensure that they are keeping their follow-up appointments, even when they feel they are doing well. This will not only improve the quality of life for heart failure patients, but also save the hospital money that can be used to continue to build on and improve the current project. Thank you.